Welcome to our second presentation of our 2021 Southwest Affiliate Stroke Educational Series. This particular presentation is Best Practices in TeleStroke. My name is Deb Motes and I will be your moderator today. Feel free to ask questions throughout the presentation by typing them into the little box down there on the side at the bottom of your screen, or if you're using your phone, you can press *6 to come off mute. It's my pleasure to introduce our Johanna Morton. Dr. Morton is a board-certified vascular neurologist with over 14 years experience. Currently, she's the vice chair of neurology and the stroke medical director of Specialist on Call, or SOC. Dr. Morton has extensive stroke clinical research experience and previously served as both a comprehensive stroke center medical director and TeleStroke program medical director at 2 hospitals in Austin, Texas, in which she led the development of both comprehensive stroke centers. Additionally, she's certified in medical quality by the American Board of Medical Quality, and Dr. Morton is also a disease-specific care stroke reviewer for the Joint Commission. She is very interested in stroke systems of care and is on the Governor's EMS and Trauma Advisory Committee, Stroke Committee in Texas. In addition, she serves on our Southwest AHA Stroke Committee. I will now turn the presentation over. Dr. Morton.
Thank you, Deb. Can you hear me okay?
Yes.
All right, let me share my screen. All right, can you see that okay?
Yes, perfect.
All right, so good afternoon. Thank you for inviting me to speak today. I'm excited to present on the topic of telestroke. I'm a full-time telestrokeologist, and I am presenting virtually today from Austin. So, when I reflect upon my experience in telestroke, the phrase herding cats comes to mind. I don't know if anybody's herded cats in the past, but it's actually impossible to do. And I use this analogy for building or managing a telestroke network for one reason. It's that telestroke isn't about technology. It's really about people and human behavior, which are really the key ingredients in the process of telestroke. And so getting people to do things that are different or that they don't want to do is actually very challenging. So that's why I use that analogy. Now there's so many components that are really difficult to align in telestroke. It's not really just a neurologist, a computer, and a telemedicine cart. Many telestroke networks have more than one type of hardware or software or packs. And then you have to juggle the perspectives of IT, neurology, the ED physicians and nurses, patients and family, and components like triage and backup solutions, if there's not enough manpower or IT issues, really have a lot of different moving parts. So the quality team also has a challenging task of reviewing both the clinical and the operational performance. And the requests of non-clinical stakeholders, such as operations, finance, and administration, need to be weighed with what the clinical team feels is best practice. So that being said, today's goals of our talk, we have a couple objectives to have a high-level conversation about preparatory steps when you're implementing a telestroke network, to review the implementation roadmap if you're launching a new network or just adding a single site, keys to the success for a program like monitoring, performance improvement, the what ifs, and then some tips and tricks from best practices as well as things to avoid. And the audience for today's talk is really anyone who runs a telestroke network, participates in telestroke, expanding their network, somebody who solely practices telestroke like myself and wants to improve the quality, especially those who are adding on non-health system sites. It can be challenging. And then obviously neurologists who are looking to supplement their career with telestroke. So we all know that telestroke is the future of stroke. It develops expert care to regions without local or on-site vascular neurology. And by doing so, it allows the office neurologists to really stay in their clinics and be more efficient. And it allows for neurohospitalists to focus on the care on the inpatient side, which is the family meetings, the multidisciplinary rounds, complex patients. And really concerning for our profession, it really serves as a mechanism to potentially help reduce burnout. And I like to call this stroke code respite. I think everybody needs that once in a while. So, telestroke's been around for a long time. It's not new technology, but just because it's old or established doesn't make it straightforward or effortless or even easy. So when you combine technology with remote clinical presence, you definitely can create several challenges. You think, what could possibly go wrong? It sounds simple, but actually a lot of different things can go wrong, or a lot of different things can be suboptimal, which is really not acceptable in the world of acute care, acute stroke care. And really a solid telestroke program is more than just a satisfactory end product. It's actually the effective process. And there's a multitude of variables that can fail or underperform. So when we're developing a telestroke network or expanding the network, it's really important to pause and do some preparatory work. So before you begin building or reassessing your telestroke program, it's important to take some preparatory steps. So first, we identify what is the goal of the telestroke network. It's really important to keep the scope broad because it's better to be over-prepared now than to scramble down the road in time of need. So what exactly is it that you're trying to provide, and does it vary at different sites? So should the telestroke program cover just stroke alert activations, which is subjective, or just yes or no to TPA? Or should the program actually cover all neurologic emergencies like stroke or seizure status, while the local neurologist can see routine consults at as their schedule permits? Should the telestroke program provide ED coverage only, or should it provide coverage on the inpatient side as well, kind of like a neurohospitalist would act? And sometimes the telestroke network really just provides supplemental coverage for a daytime on-site neurohospitalist, so like nights and weekends, or just ED coverage. And then there are telestroke networks that are everything, because there's absolutely no neurologist like for hundreds of miles from the facility. And I think more and more we're seeing that telestroke's being used to support a single neurologist at a hospital, kind of for backup, like nights or weekends, vacation coverage. And that, still helps prevent burnout and increase job satisfaction. And of course, all of these details matter. It definitely can affect your telestroke network. So number two, I'm trying to learn more about the nature of the services that are being requested and the problem that needs to be solved. So what kind of facility is it? Is it a high functioning comprehensive stroke center that's a well-oiled machine and really just needs supplemental coverage? Or is it a non-accredited low volume stroke center that doesn't really have a lot of stroke expertise or experience? And then what kind of resources does the facility have? Are there dedicated educators, stroke coordinator? Is there a medical director who has stroke expertise and actually provides input to the staff? Or is there like a 0.1 FTE stroke coordinator who manages all the other clinical programs as well? Quite often the telestroke physician can be the only link to stroke care at the facility. So does the facility simply want just a doctor on the screen, or do they actually want an engaged team member that really participates in the stroke program? And then what's the depth of the services that are requested? Is it just a yes or no for TPA? Is it a complete teleneurology consultation for the stroke mimics, the rule outs, those types of things? Do they need the physician, the telestroke neurologist, to call the neurointerventionalist or the transfer center? Do they need them to call the admitting hospitalist or the ED physician? So it really can vary from site to site. So after scope and depth are known, it's time to start drafting some potential solutions. And the first thing to do is pick your project leader who's really going to carry the momentum and accountability. And it should be somebody that's not voluntold to do the role, but actually somebody with passion, dedication to the cause, who's compensated as well. So who's the workforce? So survey your current neurology staffing, your resources. Is it going to be the neurologists who already have to do hospital service and emergency department calls and clinic? Is it going to be the neurologists who have gaps, some flexibility in their schedule? Is there an advantage or disadvantage to having just general neurologists cover telestroke? And sometimes the clinic neurologists are kind of roped into telestroke because they have a little bit more flexibility or gaps in their schedule. Or a lot of times neurohospitalists end up doing it because they have flexibility when they want to round and can kind of own their schedule a little bit better than clinic neurologists. And they're also more familiar with inpatient stroke care. And ideally, should there be a dedicated team of telestroke vascular neurologists if the volume is sufficient? So really the coverage model just reflects the needs of the sites as well as the availability limitations of the neurologists. So the next step is to really learn the organizational culture at the spoke site to really understand whether or not the proposed solution is going to mesh with the facility. And this isn't really often discussed, but it's super important. So what's the current coverage for stroke at that facility? Is it like a community doctor with a busy practice or a Monday through Friday neurohospitalists or nothing? And how do they handle gaps in coverage in their call schedule? What are some things that have worked for that facility for stroke call coverage, and what hasn't worked? Like, do they just call the neurologist's cell phone number? Are they having the ED physician triage the EMS pre-notifications for stroke? Are they having an in-house neurohospitalist take stroke call? And sometimes they're actually pulling the physicians out of clinic for stroke call. And understanding that organizational culture is really important. How does the hospital or the spoke site prioritize high quality over cost? Like, is a stroke program valuable to the hospital? Does stroke coverage not work because the neurologists weren't compensated for stroke call? How are things done? What are the values and beliefs of the administration, and how does that translate to employee behavior at that spoke site? What types of educational resources are available at the spoke site? Who can educate the staff on stroke protocols and pathways, and the use of telemedicine? Have they ever used telemedicine before, and how was it received? Was it a tool they were grateful to have, or was it an annoyance? And I've definitely seen both sides of that. Who's available to train the staff on the use of telemedicine? Is there a site champion? Is there local IT support who actually understands the telemedicine TeleStroke network? And what's the spoke site's approach to stroke care? Are they anti-alteplase? Are they cavalier and don't even wait for neurology? Do they screen for LVO syndromes? Are they proud of their stroke program, or is it really neglected? So I think on a scale of 1 to 10, collectively, you need to take into account what's the facility's resources, their stroke fund of knowledge, their protocols, their IT support, and what do you think you're going to have to do, or who you're going to have to work with on a one-to-one basis to get them ready and up to speed to be able to do telestroke? So really, does the facility have the resources that are required to deploy a successful telestroke network? So once scope and breadth of the project is known and some solutions are drafted, sites have kind of been surveyed, it's really time to dive into a gap analysis. So at some point, multiple stakeholders are going to be involved in assessing the readiness. IT has to meet with the hospital and the telestroke physicians to make sure the hardware on both sides is sufficient. Then IT also has to make sure the software on all the platforms is adequate. Physicians have access, which a lot of times requires admin logins to check installations, VPN access, and all of those pathways need to be checked for reliability and maintained. And has a spoke site champion been identified? Who's providing the administrative support? Who's going to make sure that cart is online, charged, and ready to go on a daily basis? And who's writing the telestroke protocols? Is it the hospital side or the telestroke side? And is there enough staffing to even support telestroke? Because it really does require one-to-one nursing to assist with the exam. Are there nurses NIH stroke scale trained to assist with the exam? And how is that going to be accomplished if it's not already set up? So what are the additional educational needs that the staff needs regarding stroke or TPA, those types of things? And who's going to educate the staff regarding the new protocols that incorporate telemedicine or telestroke? And how do we know that the staff is ready for go live? Testing of the IT components and the clinical pathways are best done with mock telestroke alerts. Inevitably there's going to be troubleshooting that's going to need to be done, after the go live date. So is there adequate IT resources who are dedicated to support ongoing troubleshooting? So who's going to be doing the performance improvement? So is it going to be on-site data collection? Will that be outsourced? And how will non-quantifiable concerns like professionalism, clinical integrity, and those types of things be addressed? So the gap analysis really prepares the organization to get telestroke from point A to point B. So it feels like a million different things to take into consideration, but it's really not that complex. So having built a couple of programs, I've learned that it's really important to be at peace with your available resources. Otherwise, the journey is incredibly stressful. When building a program, most likely one will not have enough staff, resources, equipment, or time. And even the most well-resourced programs probably are actually lacking some key components or resources. And there's no perfect program, and it's really not constructive to complain about lack of resources. It is important to have administrative support and a non-clinical project leader. But once you realize, what you're working with, you really just have to roll up your sleeves and get creative with solutions. I think creativity and problem-solving skills are really just essential in this type of environment. I think Delegating responsibility or accountability to other stakeholders allows them to own a piece of the project, and they're typically more knowledgeable in their little area, and that actually helps allows for more potential solutions to an issue, and it also brings the accountability to the stakeholders. And sometimes it inspires them to meet their deliverables. So the project leader unfortunately can't be everywhere at all times, so it's really important to have a strong infrastructure of support, and it's really paramount to the success of the program. So sometimes the sites, or often I would say, the sites will have people who are really passionate about technology or about stroke, and those people are really helpful to have them engaged serving as stroke champions or telestroke champions. So they're not really officially in charge, but they drive the necessary change, and they kind of act as the cheerleaders to keep that project moving forward on their successful path. So make sure to recruit and reward telestroke champions to help the program succeed. And one of the keys to success is to really know your facility. It's unique as a traditional relationship. And I think it's important to know that telestroke thrives when it caters to the needs of the relationship. So there are probably things that they do great at the facility, things that they don't do great. And it's really important to be mindful of both and incorporate that into workflows. So one thing I would say is you must meet the ED physician group, earn their trust, earn their buy-in, learn their attitudes towards stroke care and TPA. Another important group is the nurse managers and educators, meet them in person and try and see if they include stroke or telestroke in their education. And this group is very influential on the attitudes of the employees towards stroke care, and get a sense of where stroke stands in the ED in the hospital based off of these conversations. And then additionally, try to learn the facility's attitudes towards telemedicine. Are they reluctant of change? They don't want to have the remote presence? Are they excited for the new opportunity? So think of it as a relationship for sure. So now it's time to assemble your team. Um, nobody wants to feel left out. I think inclusion is vital, and it helps foster buy-in, which I've said multiple times, and it's very important for the program's success. So the core group of stakeholders is going to have the clinical leaders of both the program and the spoke site, as well as the local neurologist and the telestroke neurologists. The program or the project managers of the telestroke program and the spoke site might be different. So really important to have both sides on the team. Key departments that are involved in the acute stroke process need to be at the table as well. Nursing leadership, it's essential because, like I said, it's the infrastructure in the emergency department for processes, education, training, expectations. Administration should be involved. They're potentially the gatekeeper for additional resources. So, important for them to be there. And then quality and analytics need to be at the table to review clinical and operational performance regularly. Of course, the dream team would have additional people like neurosurgery, ICU, hospitalists who receive the patients, radiologists, neurointerventionists for feedback. I do think that all of the telestroke neurologists should be invited to stakeholder meetings because they really have unique insight into how the process works. And a dream team would really have clinical informatics because they're really the link between the IT team and the clinical team. So when preparing for TeleStroke Go Live, practice makes perfect. You can never, ever have too much practice. So everybody needs to be involved in the practice runs, regardless of experience, either in technology or stroke. So all the neurologists should actively be participating to make sure their bandwidth works, hardware, software, no glitches. IT team needs to be on standby so that they can kind of identify any glitches or snags that come up. I think access to PACs and VPNs needs to be confirmed because accounts expire, they get locked. And sometimes VPNs are a little bit challenging because they can actually take over your entire computer, and you don't realize that until you're doing your first case. Where are the neurologists documenting in the native EMR, shared EMR? How do we make sure that everybody gets the records they need? And has the data team been notified about which metrics to abstract and when the go live date is? And so mock telestroke codes really are the best way to trial the system because all components of the process are tested and the rate limiting steps are identified. If that can't be done, a walkthrough maybe in the emergency department can be done where we talk about what would happen if we were going to actually do the process. But all issues, regardless of how small they are, really need to be identified with a timely action plan that has a confirmed resolution prior to the go live date. So now that TeleStroke's ready for go live, we need to start thinking outside the box of troubleshooting. So what's the plan when humans fail, technology fails, the system's overwhelmed? Because I see this every single day in my career. There needs to be workarounds for missing components, right? So software down, hardware down, missing neurologist. How do we handle multiple code stroke activations at once? If we can't reach the neurologist, the your phone ringer's off, cell phone coverage is down, like what's the next step? What if the PAC server's down, or there's connectivity VPN issues with the facility or other information systems? Or what if the neurologist has multiple acute patients from either other sites or their primary workplace? How is that resolved? And I think one of the best ways to think about your vulnerabilities is to think about what's going to happen on a Saturday evening at 3 a.m. So skeleton crew, limited resources, less IT support for troubleshooting. So I think the questions are, is the IT team at that time knowledgeable in telehealth and able to help remedy any problems that develop? And are all those solutions acceptable to all stakeholders? So of course, obviously don't wait until a high stress situation to come up with those potential solutions. So how do we define telestroke success? Well, it's important to monitor relevant process measures to ensure that the telestroke program is performing at a satisfactory level. Most of these are very similar to acute stroke door 2 times, but some of them are actually specific to telemedicine telestroke, such as, door to telestroke consult request, door to response of that telestroke neurologist, or the request to response time. How long is that video consultation taking, or how long is the entire consultation from start to finish taking? And the time from the telestroke consultant to the needle time. So things to focus on are really, how long does it take to request the consult, and when is that consult requested in the process? Is pre-notification being used for teleneurology? What's the neurologist response time, and how long do TPA decisions take once on video? Additionally, outcome measures further define your program's quality of care, like outcomes, complications, functional status, diagnostic accuracy, TPA rates, hemorrhage rates, all those things that are important to a top telestroke program. And that's all really beautifully outlined in the 2017 AHA telestroke quality scientific statements by Dr. Wexler. But since not all patients are or since patients are often transferred, sometimes it's hard for the telestroke consultant or the telestroke program to follow up on some of those measures and metrics. So to that end, it's super important to have a clearly delineated agreement for data sharing in case the neurologist doesn't round on that patient the next day, or they get transferred or whatnot. That's the only way really quality improvement can survive. All right, so in addition to the performance metrics, telestroke programs really should be reviewed for appropriateness of care and other qualitative stuff. And it's important to measure this at different levels within the program. So, at the system level, are the neurologists recommending the appropriate level of care? Are transfers being utilized appropriately? I think routing of patients will quickly get administration's attention. So it's something to be mindful of when looking at telestroke and best patient care. At the facility level, what are the telestroke response times? How reliable is the service? Are the door to needles and TPA rates benchmarked against in-person care or just national standards? Is the clinical integrity of the cases consistent with the expectations of the organization? And then are the telestroke physicians professional and enjoyable to work with despite the challenges and barriers of telemedicine? And do they even communicate effectively with the patient or the local physician? At the teleneurologist level, are the telestroke physicians happy with the site's preparedness? Do they have the tools that they need, like the bedside nurses help or easy EMR PACS access, phone numbers for neurointerventional? Is the site receptive to the modality and their recommendations? And are consults being called to the telestroke team appropriately? And at the patient level, does the patient accept the teleneurology consult? Do they even understand why the physician's not at bedside? And do they accept the consult in lieu of an in-person neurologist? Are they valuing, that immediate access to a specialist? And does the telemedicine consult cause any barriers to understanding the care plan? Are they even happy with that experience? So all things to take into an account. So some tips that can help improve the success of a multi-site telestroke program. A lot of programs cover 6, 10, 20 primary stroke centers. I think data transparency is really an underutilized component when it comes to data and multiple stakeholders. So, like I said, it's really important to share data at all levels, and it should be reported regularly through the appropriate channels, so accessible to leadership and end users, which helps facilitate end user engagement. When you provide telestroke services to multiple sites, it's important to share data, system wide, which is a reason to have system or network level meetings. Because of the amount of data, sometimes the meetings are separated out into clinical data and operational data. But the meetings should focus on successes and challenges, because the spoke sites can really benefit from hearing what works and what doesn't work. Clinical data should be reviewed, of course, but the operational and IT challenges may or may not be similar throughout the network. And discussing them together can help everybody troubleshoot and work together. In addition to the systems level programmatic approach, each spoke site should have site-specific data. And of course, all the process and outcome measures should be reviewed at the site level, and then the PI plans built accordingly. So now that we've done the prep work, we've launched our TeleStroke program, we've made it to implementation, we've been actively reviewing, monitoring our data. Now what's next? Well, of course, we're going to brainstorm about what potentially can go wrong, and then we're going to troubleshoot all of those things. So we've touched upon this before, but the coordination of care through a telemedicine network really deserves additional attention because it's an integral part of the telestroke success. So when designing the program's infrastructure, how are consults requested and distributed? So there's a lot of different variables, such as, whether the hospital is in the system or out of the system. How many facilities are there? What's the scope and breadth of the coverage at each facility? And how is projected demand incorporated, if at all? Many systems use a coordinating center or transfer center with nurses who triage, or even sometimes more of an elaborate platform. Others use just direct cell phone for the neurologist or whoever's on call. Can a telestroke team member, triage the calls and just kind of figure out based on triage severity time? I think the question is, if they're going to do that, who's going to be the one who decides which patient needs to be seen next? Is it sufficient just to say one person's the telestroke person on call and just use a single pager system? I think that would work fine, but that's really only if the system is very small and calls come one at a time. I think telestroke systems with multiple sites often experience multiple critical consults at once. And how does the network plan to deal with that? Is that by a triage system? And if so, who's the triaging? If somebody's triaging patients, and who's performing the consults? And then what is the backup system if another physician is really needed because of a critical complex case? Now, how are the physicians who are off reached for help, or should they even be contacted on their days off? Are the neurologists incentivized to help on days off? And something that needs to be thought about, how does IT handle multiple telestroke connectivity issues or EMR PACS issues? Do they have the resources and backup similar to a neurologist having backup? And then how does the telestroke network plan to be involved in care coordination? So are there expectations that the telestrokeologist will speak directly to the accepting physician via transfer center? Will they be expected to call the interventionalist and make that decision together as a team and talk to the ED physician? And who would determine the transport type that's necessary, and who's going to make the final say as to which facility that patient goes to? And currently volumes might be manageable, but the old adage of if they build it, they will come is definitely true in telestroke. So plan for an increase of stroke volume for sure. So there seem to be some black cloud vascular neurologists who seem to attract multiple code strokes at the same time, and I happen to be one of them. Quite often, telestroke networks have more than one consult at a time. So this requires a little bit deeper of a delve. So triage in telestroke, or triage in regular stroke, meaning in-person coverage of an emergency room, maybe a second hospital, is fairly easy, but it's an incredibly difficult beast when you're working remotely, virtually. Sometimes you call the requesting physician to get an idea of the scenario, but from experience, this has been fraught with inaccurate summaries, only to find out once you go on video that the situation is completely different. And it also takes valuable time away from other patients while you're waiting on hold for that ED physician. So then that begs the question: who should be calling? It's not really worth taking the physician's time if they're that busy. So should there be, a telestroke nurse or a non-clinical staff member who can call and get key components? This, if you add up, multiple stroke centers, this can be an incredibly time-consuming endeavor. So, sometimes from experience, texting or calling, a colleague is generally effective, but it's not perfect. And especially again at 3 a.m. on a Saturday night, how do we guarantee availability or reachability, on an off hour? So I think it comes down to expectations of the hospital. So we know that phone consults are suboptimal to doing your own exam, but in some cases it's actually acceptable and a safe alternative. So if the facility is okay with this, then that would be a perfect solution. But some facilities are not okay with that. So then multiple telemedicine carts need to be available. And then what's the agreed upon time for how long an IT professional should troubleshoot, a non-functioning AV system or some component that's missing before a phone consult is deemed appropriate? So all of these expectations need to be clearly defined. How do we guarantee that a telestrokeologist will be available for backup? How do we pay for their time so that they don't go to happy hour or go for a marathon run, even though they might not be involved in any clinical work and we might just pay them to be available? Is there a shared responsibility model within the neurology group? Or do we incentivize backup requests for help, or do we just pay them to be on call just in case? One thing is important to point out that it's really important to look at outcomes and data during high volume periods or critical peaks in consults, or when the neurologist's availability is limited, because those are areas at risk, and that should be reviewed by the site and the system to ensure that that current Plan B system really is effective and safe for telestroke care. So when telestroke care is provided across multiple sites, of course, you're going to have variations of different designated stroke center levels, but you're also going to have different clinical information systems as you jump from hospital system to hospital system or community hospital. Now most systems use EMR and CPOE, and it's incredibly helpful because you find out a wealth of information that you don't get from the firsthand story from the ED physician. But it allows the physicians down the road to see the consult note, understand the thought process. And of course, orders often are being placed by teleneurologists for, thrombolysis or additional imaging. So it's really important that this process works seamlessly, but the more accounts and passwords you have, the higher chances of something being disabled, expired, forgotten. So creating a system to maintain accounts and passwords and expiration dates are really important, because you don't want to be scrambling in the middle of a stroke alert when you find out you're locked out of an account, and that requires a phone call and not just a web link to fix your password. And I mentioned this before, but remote VPN access can be incredibly cumbersome. There are certain health systems that when you log in, it will wipe all of your your monitors, so you're just looking at the VPN. So if you're trying to use a different information system or a separate PACS, you can't do two things at the same time. So those things need to be troubleshooted ahead of time. So, regarding PACS systems, so some telestroke companies have all the imaging come to the telestroke company, but then other companies actually log into native PACS systems. So again, multiple logins, multiple accounts. On the topic of imaging, do any of the facilities have advanced imaging like VIS or Rapid? And what are the CTA protocols? I think, in the hundreds of hospitals that I've worked in, there's different variations probably at almost every hospital. Are patients getting CTA upfront every stroke alert, regardless of severity? Are they getting shipped out for CTP or Rapid? And how are the neurologists supposed to keep track of that? Should they be looking for, CTP, CTA? Is Rapid and VIS being sent to the telestrokeologist's phone, like via an app? And that requires a lot of configuration on the health system side to have that whole telestrokeologist panel receive those notifications. So each site really probably has a different way of, who reviews, who's interpreting the imaging, what imaging being done, and it's really hard for the neurologist to keep track of that. And also different hospitals request different things from the teleneurologist regarding conversations regarding, neurointervention and transfer and local neuro IR versus comprehensive stroke center neuro IR. So are those other professionals amenable to the phone call? Are they open to the case discussion, or would they just rather have everything sent to them? So a lot of details that need to be ironed out. So this screenshot here is from several years ago, and it's really an example of a true learning experience for myself. As I was working on a TeleStroke project, I thought I had all the planning and education done and rolled out and ready to go for the launch, and obviously I was very wrong. I think one thing looking back I could have done better was really assess the educational campaigns. And now I look back and laugh, but one thing I cannot stress enough is that it's important to educate and then educate again and re-educate. And I don't think you can really over-educate. However, it's really important to assess that knowledge. So you can talk or you can send emails until you're blue in the face, but if nobody's listening, if nobody's reading, it's a waste of everybody's time. And honestly, I mean, nobody reads all their emails. So to that end, it's important to make the educational emails easily searchable for a quick reference when they're needed. I think it's important to learn your target audience's learning language. Most likely it's not email. And actively check in with the neurologist to make sure IT competencies are satisfied, troubleshooting's occurred, they know what the protocols and pathways are. I've learned for some reason trying to get neurologists to do new things is like herding cats. Now, I work with a group of 80 physicians, so it's quite painful to implement change. So identify any potential problems before go live as a result of actively assessing the knowledge of your physicians, and identify those weak areas or users or problem children that might need additional support before go live. For some reason, some neurologists need extra hand-holding or coddling to get all their ducks in a row. And don't let anybody sit out of mock telestroke alerts. To me, that's just completely unacceptable. No matter how busy somebody is, no matter how experienced they are, whether it be technology or stroke care, and especially those who have less clinical shifts, really everybody needs to have a practice run before go live. So having done this for a couple years, I put together some pearls of wisdom to help those building or expanding their telestroke program, or just those who are seeking opportunity for improvement. So I think pearl number one is patience, which I learned the hard way. Not all facilities have the resources that we took for granted in residency or at large academic stroke centers. And I learned that more and more as I do community neurology, that a lot of facilities are really struggling. Facilities that use telestroke quite often may not have neurology resources available. Their nurses might not be NIH stroke scale trained. They might not have alteplase training. They might not have a stroke coordinator or a medical director or a nurse educator. So, many facilities are really struggling with staffing levels, with up-to-date technology, with access to specialists, even more so in a post-pandemic world. So stroke, we know stroke code activations are high stress, especially, for the staff, the patients, the nurses. And the staff might not be doing everything that you would expect or how you learned it to flow, but they're really not trying to aggravate you. They're really trying to do their best. So at the end of the day, I think we can say we all want what's best for patient care. So I think doing telemedicine, it's really important to be patient and have realistic expectations and work together. So often a telestroke network has these smaller community hospitals not directly affiliated with the healthcare system. And so I mentioned before, like when that setup comes up, there's a lot of different protocols, access, VPNs, EMR, and that provides like an additional level of chaos. And it becomes really challenging, especially if you have a large system. Like I have 100 privileges, so it really gets challenging when I'm trying to figure out where I am and what hospital I'm at. What's the level of stroke care? Do I use EMR? Do I not use EMR? Which PAC system do I go into? What's the link for this, that, and the other thing? Do I call a neurointervention, or does the ED physician call neurointervention? So those type of things, it's almost impossible to keep straight. So one thing I found that's really helpful is like a user manual type link for each hospital, where you can just click on a link on a desktop that has EMR, password reset, PACS, protocols for stroke, for transfers? What are their capabilities? Do they have rapid viz, CTP, none of the above? Facility specific requests. I mean, some facilities have unique, requests that they might have. And having that quick reference guide that describes the facility specific stroke care really benefits the TeleStroke program, and it can remarkably improve efficiency, accuracy of care and expectations. And another pearl that's not really often talked about is etiquette. So we're not robot doctors. We're actually physicians who have dedicated our lives to really helping those with neurologic disease. And sometimes that compassion can be lost by the telemedicine modality. And, it's a topic that should be discussed at meetings with neurologists and, feedback to the spoke sites, but it's usually not. And, being neurologists, we're not typically known for our social finesse and, adding the audiovisual communication barrier. We can't even like shake somebody's hand to greet them or provide comfort. Since stroke activations are high stress, it creates a challenge. I think it's really important to be cognizant of the patient and the family's body language and social cues. That's one thing you can really take note of when you're on video, and just be mindful that you're not there in person to do the things that you would do. And it also applies to like the ED physicians and the nurses. There is a physical distance, but you can kind of lessen that distance with a warm demeanor. So flexibility is really important for teleneurologists. The patient or the nurse might not know all the answers or understand your requests, or the pharmacy might take too long, but it's important to be flexible, patient, as if you were there in person, even though you're having some internal frustrations. So I will just add that, a little compassion goes a very long way in telemedicine. So if you pay attention to only one slide for the entire presentation, I would say that this is probably the most important slide. Expectations within a telestroke program are very important and are rarely ever discussed. They're not always clear. End users, the people that use the program every single day are rarely involved in the planning or the implementation discussions. And so small but super relevant details that only they might know are not really addressed or identified. So this can create frustration on their side towards the telestroke program, in which the end users can develop a negative attitude and translates into a lack of support for the program. And that can actually completely derail the telestroke program. And it's really, really important to keep in mind that everybody's coming into this with a different perspective, right? So the ED physician, sometimes they want a full neurology consult and a conversation, or just, that, hey, patient need TPA or not? Okay, great, good, have a great day, thanks. Or do they want a face-to-face conversation with you on camera, with the patient? For some ED physicians, telestroke is out of sight, out of mind. Just a little phone call heads up is all they need, or they might not even want to be bothered. The telestroke neurologist's perspective, sometimes we expect that the ED physician is going to come to bedside and have a conversation with the nurse and the family. Do we expect the nurse to be available to help us? Do we expect all the neuroimaging to be done and ready and the cart turned on and the patient knows that we're coming on, so we don't scare the bejesus out of them when we remote onto the screen? Do we expect receptive neuroradiologists and neurointerventionalists to have that clinical conversation? Do we want to feel appreciated? Yeah, sure. What does the expectations of the bedside nurse look like in telestroke? Are they expected to just set up the cart and walk away and let the neurologist kind of do everything? Or are they expecting to be there, to help facilitate the consult or telepresent and assist with the exam? Are they expected to participate as part of the team? And I think, we take it for granted that the patients understand what's going on. The patient's perspective, are they understanding of, why you're coming up on screen? And again, I've scared a multitude of patients in my career because nobody told them that we were even going to pop up on a video screen in their room. Are they accepting of that technology and that person really just can't be there in person? So I think as you're planning out and thinking about how to improve a telestroke network, it's really important to be mindful of your perspective and, of expectations as well. So as I was thinking about pearls and pitfalls, I came up with several more pitfalls than pearls. So here they are, in hopes that some of my struggles will help somebody who's building a program. And I think, We talk about buy-in a lot. Another thing that's really not mentioned is physician buy-in, because it's complicated and it's challenging, but please do not underestimate the power of physician buy-in. Nobody wants to be left out. Everybody wants their voices heard. Change is hard. New processes in healthcare are kind of stressful, but it's really important to listen to the concerns of your stakeholders and validate those concerns and keep them engaged. Be appreciative of the extra eyes that provides that larger perspective on the TeleStroke program or project. Be thankful for their concerns, because those concerns really benefit the TeleStroke program. So really take them to heart. If those concerns are addressed, people, especially physicians, are more likely to support the project. And in a world of corporate healthcare, the process really should be or remain physician driven. As the project evolves, more physicians are involved. Be respectful of their feedback and understand their perspective. Their concerns need to be validated for continued buy-in for the TeleStroke program as it evolves. So make sure to incorporate their opinions and concerns during the initial implementation and beyond, for sure. Pitfall number 2. So it's something that we just need to keep in mind, that if something will go wrong, it 100% will absolutely go wrong without a doubt. Every single day in my practice, I have a hardware issue, I have a software issue, I have a human factor issue, and then I just have random things like my internet just disappears or my cell phone doesn't notify me. I mean, like every day there's just at least one problem. So, luckily, all of these things have been thought out with multiple levels of backup systems, but those things take time to be set up in advance. So think about, the doomsday type preparations now, and not during that code stroke activation at 3 a.m. on a Saturday night. That the backup plan might be unique to the facility. Some facilities are totally fine with phone consults. Others are absolutely 100% not fine with phone consults and want a video consult. So they're a little bit more lenient with, Skype and kind of non-encrypted type technologies. So the plan is really less important than just ensuring that the clinical team and the site are comfortable and in agreement with the plan. High stress situation is not the time to figure out plan B. And, IT support really must be reliable and adequately staffed and resilient to be able to take on telehealth issues, in addition to all of the other issues that they're dealing with within the health system on a 24/7 basis. So the next pitfall, last pitfall, is that telestroke can be really isolating, especially if it's like most or if not all of the clinical workload of the neurologist. And speaking from experience, it can be an isolating work environment. I sit here by myself all day, every day, with my dog, who's right here. And, it creates kind of a barrier to care and communication. I mean, throughout my training, I would walk into the emergency room, talk to the ED doctor, talk about their day, talk to the family, shake hands, walk the CT with the patient, talk to radiologists down the hall, um, text my neurointerventionalist. So, obviously I can't do any of those things through telemedicine. So with remote work comes limitations. So it kind of creates this impression of like clinical silos, which can kind of deter from the development of the normal relationship the neurologist usually builds with the family and the patient and the other physicians involved in care. And it's really critical in high stress stroke alert situations. And I think vascular neurologists are just we're used to a collaborative environment of stroke neurology. So because of the remoteness, and we identify with being on a team, it really can affect the success of telestroke. So it's something that needs to be considered. So I encourage all of the neurologists to give the extra mile when care is being delivered remotely, and kind of, deliver care how you would expect it to be in person. So try and act as if you're physically there, and try and imagine that there's no telemedicine barrier. And so that means more time with the family, more time with patient and nurse than you normally would take. Extra phone calls, kind of wrap up things, tie up loose ends. To make an effort to call the neuroradiologist or call the neurointerventionalist. Kind of make sure everybody's on the same page with medical decision making and the plan of care. I think the telestrokeologist needs to be mindful of the limitations and how those barriers can be overcome, especially in its early stages, but they definitely can be overcome for sure. So in summary, so number one, take time to do the prep work prior to implementation. So know exactly the details of the program, the problem that you're trying to solve. implement change in an organized manner. So you want to map out all of the details and forecast potential site-specific barriers. And then, of course, monitor the system post-implementation, not just process and outcome measures, but satisfaction and success from different angles, and then maintain data transparency with all stakeholders. And of course, you want to brainstorm what ifs, hardware, software, coverage, failures, and be mindful of the human factor. You want to obtain buy-in, be mindful of different perspectives and expectations, and make sure the extra mile is being taken to prevent the clinical silos from developing. And then I would say, lastly, be patient. It's very difficult to build a complex telestroke network, but when it does run smoothly, it's absolutely an amazing asset to both the hospital and the patients who need that acute stroke care. And I think with that, I want to thank everybody for your attention to my talk. If anybody has any questions, please feel free to reach out.
Thank you, Dr. Morton. Excellent presentation. If anybody has any questions, feel free to type them in the chat box or *6 to unmute yourself so that you can ask Dr. Morton. I'm seeing thank you for your time. And I saw a comment earlier that says, it's like nailing Jello to a tree. That was kind of funny.
Awesome.
So I'm not seeing, oh wait, do you find that it's important for the patient, for the neurologist to also be on camera?
I find it's important for the patient. Yes, absolutely. Sometimes when I'm on video, they can hear me but can't see me. And, I do my best to try and troubleshoot that, in a timely manner. A lot of times, I just had my last case last night, the patient was very skeptical and the wife was looking at me, literally her head was crooked. I could tell she just was not having anything I was doing or saying. And it just took really like an extra time with her. And I kind of convinced her, and then she was really empathetic and thankful. So yes, that is a huge component of building that relationship with the patient. Absolutely.
Thank you. What is your door to needle time goal for telemed cases? 45 minutes, 30 minutes, median time?
I would say my blanket statement for that question would really be, it's no different than whatever your door to needle time goal is for your regular stroke cases. So depending on what, how your historical data has, projected, I think everybody should be working at least on 45 minutes at this point. We see cases of 30 minutes regularly, but it really depends on the facility, the protocols, and a lot of different variables. So I would just encourage people to not say, oh, this is my TeleStroke door to needle time. I would say this is your stroke door to needle time.
Thank you. Any additional questions? So I'm not seeing any more questions in the box. So I just want to take the opportunity to thank you so much for sharing your expertise, excellent presentation, a lot of valuable information. And anybody on the call, thank you all for joining. If you have any questions, please feel free to reach out. I can get that information or those questions to Dr. Morton, and we can get you an answer. So thank you so much for joining our education session today, and have a great rest of your day. Thank you.
Thank you.